Management of genital herpes in pregnancy. Background. Neonatal herpes is very rare but serious viral infection with a high morbidity and mortality. It is classified into 3 subgroups in the infant depending on the site of infection. Disease localized to skin, eye, and/or mouth, local central nervous system or CNS disease, encephalitis alone, and disseminated infection with multiple organ involvement. Disease localized to skin, eye, and/or mouth. Infants who present with symptoms localized to the skin, eye, or mouth alone have the best prognosis and represent approximately 30% of neonatal herpes infections. With appropriate antiviral treatment, neurological and/or ocular morbidity is less than 2%. Local CNS or central nervous system disease and disseminated infection. "70% of infants with neonatal herpes have disseminated and/or CNS infection, and approximately 60% of infants with local CNS and/or disseminated disease will present without skin, eye, and/or mouth infection. Infants with local CNS disease often present late, generally between 10 days and 4 weeks of age. With antiviral treatment, mortality from local CNS disease is around 6%, and neurological morbidity, which may be lifelong, is 70%. Disseminated disease carries the worst prognosis. With appropriate antiviral treatment, mortality is around 30%, and 17% have long-term neurological sequelae. The poor outcomes of disseminated and local CNS disease have been attributed to delays between symptom onset and treatment. Neonatal infection occurs as the result of an infection at the time of birth. In contrast, congenital herpes is extremely rare and occurs by transfer of infection in utero. Incidence. Neonatal herpes is rare in the UK. The incidence in the UK is around 50% of that reported from other European countries. In the USA, the average reported incidence is 1 in 15,000. Etiology. Neonatal herpes may be caused by herpes simplex virus type 1 or HSV1, or herpes simplex virus type 2 or HSV2, as either viral type can cause genital herpes in the mother. Approximately 50% of neonatal herpes is due to HSV1 and 50% due to HSV2. Most cases of neonatal herpes occur as a result of direct contact with infected maternal secretions, although in 25% of cases, a possible source of postnatal infection was identified, usually a close relative of the mother. Postnatal infection may occur as a result of exposure to orolabial herpes infection. Transmission. Factors associated with transmission include the type of maternal infection, primary or recurrent, the presence of transplacental maternal neutralizing antibodies, the duration of rupture of membranes before delivery, the use of fetal scalp electrodes, and the mode of delivery. The risks are greatest when a woman acquires a new infection, primary genital herpes, in the third trimester, particularly within 6 weeks of delivery, as viral shedding may persist and the baby is likely to be born before the development of protective maternal antibodies. Rarely, congenital herpes may occur as a result of transplacental intrauterine infection. Case reports suggest that the skin, eyes, and CNS may be affected and there may be fetal growth restriction or fetal death. Disseminated herpes is more common in preterm infants and occurs almost exclusively as a result of a primary infection in the mother. Although recurrent genital herpes is associated with a very low risk of neonatal herpes, recurrent herpes at the time of delivery, which is commonly asymptomatic or unrecognized, may cause the localized forms of neonatal herpes, both local CNS disease and skin, eye, and mouth infection. Transplacentally acquired HSV antibodies do not prevent herpes virus spreading to the brain of the neonate. Disseminated herpes infection in the mother. Disseminated herpes, which may present with encephalitis, hepatitis, disseminated skin lesions, or a combination of these conditions, is rare in adults. However, it has been more commonly reported in pregnancy, particularly in the immunocompromised. The maternal mortality associated with this condition is high. All immunocompromised women, such as those infected with the HIV virus, are at increased risk of more severe and frequent symptomatic recurrent episodes of genital herpes during pregnancy and of asymptomatic shedding of HSV at term. Management of pregnant women with first episode genital herpes. First or second trimester acquisition until 27 plus 6 weeks of gestation. There is no evidence of an increased risk of spontaneous miscarriage with primary genital herpes in the first trimester. Women with suspected genital herpes should be referred to a genitourinary medicine physician who will confirm or refute the diagnosis by viral polymerase chain reaction or PCR, advise on management of genital herpes, and arrange a screen for other sexually transmitted infections. Treatment, however, should not be delayed. Management of the woman should be in line with her clinical condition and will usually involve the use of oral acyclovir or intravenous acyclovir for disseminated HSV in standard doses of 400 milligrams 3 times daily, usually for 5 days. The use of acyclovir is associated with a reduction in the duration and severity of symptoms and a decrease in the duration of viral shedding. Acyclovir is not licensed for use in pregnancy, but it is considered safe and has not been associated with an increased incidence of birth defects. Transient neonatal neutropenia has been reported, but no clinically significant adverse maternal or neonatal effects have been reported. Acyclovir is well tolerated in pregnancy. There is no evidence of an increased risk of birth defects with acyclovir, famciclovir, or valacyclovir if used in the first trimester. Use of valacyclovir or famciclovir are not recommended as a first-line treatment. The obstetrician should be informed. Paracetamol and topical lidocaine 2% gel can be offered as symptomatic relief. Women with suspected genital herpes who are having midwifery-led care should be referred for review by an obstetrician, ideally after review by a genitourinary medicine physician. Providing that delivery does not ensue within the next 6 weeks, the pregnancy should be managed expectantly and vaginal delivery anticipated. There is no evidence that HSV acquired in pregnancy is associated with an increased incidence of congenital abnormalities. Following first or second trimester acquisition, daily suppressive acyclovir of 400 milligrams 3 times daily from 36 weeks of gestation reduces HSV lesions at term and hence the need for delivery by cesarean section. It has also been shown to reduce asymptomatic viral shedding. Third trimester acquisition from 28 weeks of gestation. Treatment should not be delayed. Management of the woman should be in line with her clinical condition and will usually involve the use of oral acyclovir or intravenous acyclovir for disseminated HSV in standard doses of 400 milligrams 3 times daily, usually for 5 days. In the third trimester, treatment will usually continue with daily suppressive acyclovir of 400 milligrams 3 times daily until delivery. Cesarean section should be the recommended mode of delivery for all women developing first episode genital herpes in the third trimester, particularly those developing symptoms within 6 weeks of expected delivery, as the risk of neonatal transmission of HSV is very high at 41%. 15% of cases where a woman presents with a first episode of clinical HSV infection, it will actually be a recurrent infection. For women presenting with first episode genital herpes in the third trimester, particularly within 6 weeks of expected delivery, type-specific HSV antibody testing, immunoglobulin G antibodies to HSV1 and HSV2 is advisable. The presence of antibodies of the same type as the HSV isolated from genital swabs would confirm this episode to be a recurrence rather than a primary infection, and elective cesarean section would not be indicated to prevent neonatal transmission. It should be noted that it may take 2 to 3 weeks for the result of this test to become available. It is therefore recommended that an initial plan of delivery should be based on the assumption that all first episode lesions are primary genital herpes. This plan can then be modified if HSV antibody test results subsequently confirm a recurrent rather than a primary infection. Serology can be complicated. Results should be discussed with a virologist or genitourinary medicine physician. Management of pregnant women with recurrent genital herpes. Women with recurrent genital herpes should be informed that the risk of neonatal herpes is low even if lesions are present at the time of delivery, 0 to 3% for vaginal delivery. The majority of recurrent episodes of genital herpes are short-lasting and resolve within 7 to 10 days without antiviral treatment. Supportive treatment measures using saline bathing and analgesia with standard doses of paracetamol alone will usually suffice. Vaginal delivery should be anticipated in the absence of other obstetric indications for cesarean section. Daily suppressive acyclovir of 400 mg 3 times daily should be considered from 36 weeks of gestation. There is no increased risk of preterm labor, preterm pre-labor rupture of membranes, or fetal growth restriction associated with women seropositive for HSV. The incidence of congenital abnormalities is not increased in the presence of recurrent genital herpes infection. Management of women with primary or recurrent genital lesions at the onset of labor. General management. The clinician must take a history in order to ascertain whether this is a primary or recurrent episode. A viral swab from the lesion or lesions should nonetheless be taken since the result may influence management of the neonate. The neonatologist should be informed. Primary episode. Cesarean section should be recommended to all women presenting with a primary episode of genital herpes lesions at the time of delivery or within 6 weeks of the expected date of delivery in order to reduce exposure of the fetus to HSV, which may be present in maternal genital secretions. Intravenous acyclovir given intrapartum to the mother, 5 mg per kilogram every 8 hours, and subsequently to the neonate, intravenous acyclovir of 20 mg per kilogram every 8 hours, may be considered for those mothers opting for vaginal delivery. where primary episode genital herpes lesions are present at the time of delivery and the baby is delivered vaginally, the risk of neonatal herpes is estimated to be 41%. The risk of perinatal transmission depends on the timing of maternal acquisition of HSV, with the highest risk in infants born to women who have not completed HSV seroconversion during pregnancy, most commonly in the third trimester within 6 weeks of delivery. Although vaginal delivery should be avoided if possible, in women who deliver vaginally in the presence of primary genital herpes lesions, invasive procedures such as application of fetal scalp electrodes, fetal blood sampling, artificial rupture of membranes, and/or instrumental deliveries should be avoided. Recurrent genital herpes. Women presenting with recurrent genital herpes lesions at the onset of labor should be advised that the risk to the baby of neonatal herpes is low, 0 to 3% for vaginal delivery. Vaginal delivery should be offered to women with recurrent genital herpes lesions at the onset of labor. The final choice of vaginal delivery versus cesarean section should be made by the mother. It has been reported that invasive procedures such as fetal blood sampling, application of fetal scalp electrodes, artificial rupture of membranes, and/or instrumental deliveries increase the risk of neonatal HSV infection. Given the small background risk of 0 to 3% of transmission in this group, the increased risk associated with invasive procedures is unlikely to be clinically significant, so they may be used if required. There is no evidence to guide the management of women with spontaneous rupture of membranes at term, but many clinicians will advise expediting delivery in an attempt to minimize the duration of potential exposure of the fetus to HSV. Genital herpes and preterm pre-labor rupture of membranes before 37 plus 0 weeks of gestation. Primary genital herpes and preterm pre-labor rupture of membranes, or PPROM. There is limited evidence to inform best obstetric practice when preterm pre-labor rupture of membranes is complicated by primary HSV infection. Management should be guided by multidisciplinary team discussion involving the obstetricians, neonatologists, and genitourinary medicine physicians. If the decision is made for immediate delivery, then the anticipated benefits of cesarean section will remain. If there is initial conservative management, the mother should be recommended to receive intravenous acyclovir of 5 milligrams per kilogram every 8 hours. Prophylactic corticosteroids should be considered to reduce the implications of preterm delivery upon the infant. If delivery is indicated within 6 weeks of the primary infection, delivery by cesarean section may still offer some benefit despite the prolonged rupture of membranes. Recurrent genital herpes in preterm pre-labor rupture of membranes. When preterm pre-labor rupture of membranes is encountered in the presence of recurrent genital herpes lesions, the risk of neonatal transmission is very small. In the case of preterm pre-labor rupture of membranes before 34 weeks, there is evidence to suggest that expectant management is appropriate, including oral acyclovir of 100 mg 3 times daily for the mother and antenatal corticosteroid administration. Management of HIV-positive women with herpes simplex virus infection. Primary HSV infection or herpes simplex virus infection. HIV-positive women with primary genital HSV infection in the last trimester of pregnancy should be managed according to the recommendations for all women with primary genital HSV infection. Recurrent HSV infection or herpes simplex virus infection. Women who are HIV antibody positive and have a history of genital herpes should be offered daily suppressive acyclovir of 100 mg 3 times daily from 32 weeks of gestation to reduce the risk of transmission of HIV infection, especially in women where a vaginal delivery is planned. Starting therapy at this earlier gestation than usual should be considered in view of the increased possibility of preterm labor in HIV-positive women. There is currently no evidence to recommend daily suppressive treatment of HSV for HIV antibody-positive women who are HSV1 or 2 seropositive but have no history of genital herpes. Management of the neonate. General management. In all cases, the neonatal team should be informed. Babies born by cesarean section in mothers with primary HSV infection in the 3rd trimester. These babies are at low risk of vertically transmitted HSV infection, so conservative management is recommended. Swabs from the neonate are not indicated. No active treatment is required for the baby. Normal postnatal care of the baby is advised with a neonatal examination at 24 hours of age, after which the baby can be discharged from the hospital if well and feeding is established. Parents should be educated regarding good hand hygiene and due care to reduce risk of postnatal infection. Parents should be advised to seek medical help if they have concerns regarding their baby. In particular, they should be advised to look for skin, eye and mucous membrane lesions, lethargy, irritability, and poor feeding. Babies born by spontaneous vaginal delivery in mothers with a primary HSV infection within the previous 6 weeks. These babies are at high risk of vertically transmitted HSV infection. If the baby is well, swabs of the skin, conjunctiva, oropharynx, and rectum should be sent for herpes simplex PCR. A lumbar puncture is not necessary. Empirical treatment with intravenous acyclovir of 20 milligrams per kilogram every 8 hours should be initiated until evidence of active infection is ruled out. Strict infection control procedures should be put in place for both mother and baby. Breastfeeding is recommended unless the mother has herpetic lesions around the nipples. Parents should be warned to report any early signs of infection, such as poor feeding, lethargy, fever, or any suspicious lesions. If the baby is unwell or presents with skin lesions, swabs of the skin, lesions, conjunctiva, oropharynx, and rectum should be sent for herpes simplex PCR. A lumbar puncture should be performed even if CNS features are not present. Intravenous acyclovir of 20 milligrams per kilogram every 8 hours should be initiated until evidence of active infection is ruled out. Babies born to mothers with recurrent HSV infection in pregnancy, with or without active lesions at delivery. In the case of recurrent genital herpes infections in the mother, maternal immunoglobulin G will be protective in the baby, and hence the infection risk is low. Surface swabs from the neonate are not indicated. No active treatment is advised for the baby. Normal postnatal care of the baby is advised with a neonatal examination at 24 hours of age, after which the baby can be discharged from the hospital if well and feeding is established. Parents should be educated regarding good hand hygiene and due care to reduce risk of postnatal infection. Parents should be advised to seek medical help if they have concerns regarding their baby. In particular, they should be advised to look for skin, eye, and mucous membrane lesions, lethargy, irritability, and poor feeding. Concerns regarding the neonate, clinical evidence of sepsis, and poor feeding. Surface swabs and blood for HSV culture and PCR. Intravenous acyclovir of 20 milligrams per kilogram every 8 hours should be given while awaiting cultures. Further management by the neonatal team according to condition of the baby and test results. Prevention of postnatal transmission. In 25% of cases, a possible source of postnatal infection is responsible, usually a close relative of the mother. Efforts to prevent postnatal transmission of HSV are therefore important, and advice should be given to the mother regarding this. The mother and all those with herpetic lesions who may be in contact with the neonate, including staff, should practice careful hand hygiene. Those with oral herpetic lesions or cold sores should not kiss the neonate. Appendix number 1. Algorithm for the management of herpes in pregnancy and care of neonate.